Hello, my name is Cameron. Today we're going to be covering how to do a needle chest decompression or an NCD. We're going to be covering why we perform an NCD. We're going to be covering how we perform an NCD. We're going to be covering the signs and symptoms of pneumothorax and tension pneumothorax. And then we're going to move over to an anatomical figure and we're going to discuss how to perform the needle chest decompression and then any assessment and reassessment that we need to conduct to see that the skill's been done appropriately and then is effective. So first, what is an NCD? Needle chest decompression is performed with an NCD needle, 14 gauge or 10 gauge needle. In this case, it's a 14 gauge, 3¼ inches long, catheter needle. It is used to puncture the affected side, relieving pressure from a tension pneumothorax. So we'll cover, in this case, traumatic causes of a tension pneumothorax. In this particular case, we're going to look at penetrating trauma. So for a pneumothorax, we have penetrating trauma. According to this diagram here, it's going to be the right side's affected. The penetrating trauma has gone through the chest wall into the pleural cavity. It is now allowing the atmospheric pressure, the air, to replace the space in the pleural cavity, not allowing the lung to appropriately expand or fill with air, with oxygen. This causes things like respiratory distress. You're not able to take a full breath because there is now air in the pleural cavity, not allowing the lung to properly expand. Looking at decreased breath sounds. With the compromise of the pleural cavity in the lung, you're not having any expansion of the lung, and so therefore there's no breath sounds to auscultate. You're also looking at unilateral or unequal rise and fall of the chest. Patient takes a breath, the chest wall no longer expands uniformly. You'll have one side, the affected or injured side, that does now not rise and fall appropriately. You have tachypnea and tachycardia. So with the affected lung, you are now decreasing the oxygenation and perfusion of the body. So the body is now increasing its respiratory rate, trying to intake more oxygen into the lungs, into the body, and the heart is now beating faster in an attempt to provide more oxygen to the system. And then we're going to look at decreased SpO2. The blood does not have as much oxygen available in the system because of the affected lungs not oxygenating, and the SpO2 will now drop. So for a tension pneumothorax, which is when an NCD is indicated, the word specifically tension is moving and putting pressure on the unaffected side. So in the diagram we have here, the right side is compromised, injured. The right side lung is now not expanding and taking in the atmospheric pressure, pushing pressure against the anatomy to the left side. So you'll have a mediastinal, a midline shift of anatomy. So you're pressing against the heart, pressing against the diaphragm, and then into the trachea, and then the anatomy, the vasculature, the aorta, and whatnot is all being pushed against. Here in this picture, we have a X-ray of a tension pneumothorax. You can see here all this dead space where the air is now present. The lung is not expanded. You can't see the left to right shift. Again, the affected side in this diagram is the left side pushing to the right. You can see here the heart's made a complete move over from the left to right side. You can see the diaphragm is now being pushed down and against. You can see up top the trachea has made a midline shift to the right. So now we're looking at late signs. So tracheal deviation, again, that midline shift of the trachea over to the right side. You can see in the neck is moved over. Jugular vein distension, the pressure's moving up, moving against the vasculature of the aorta. You're not getting any venous return. You get the engorging of the neck veins, the jugular vein distension. Pushing against the heart now, you're looking at hypotension because of the pressure pushed against the heart. It's not able to expand and contract appropriately. You're going to get narrowing pulse pressure similar to that in a cardiac tamponade. The performance of the heart's now declining because it can't expand and contract. So the systolic is going to go down, the diastolic is going to go up. You get those narrowing pulse pressures. And then you're also looking at ultramental status. So in the beginning with that respiratory distress, you're kind of looking at agitation and anxiety because they can't take a full breath, they're hurt, they're injured. And now you're looking at ultramental status, so you're looking at hypoxia, where you're looking at AVPU and GCS declining. They become agitated, they become combative, they no longer following commands, things of that nature. So moving over here, we're going to look at the anatomical figure of how to appropriately locate the sites for an NCD. So we are looking at the second intercostal space over the third rib, and then we are also looking at the fourth or fifth intercostal space over the fifth or sixth rib. And of course, when we're performing these skills on patients and in training, we will have appropriate BSI. For the indication of this class, all that is annotated is presumed that we are going to have BSI for the purpose of the class here. I'm just going to show you the appropriate sites and the appropriate technique to perform the skill here. So we're going to palpate the anatomy for the mid-clavicular site. We're palpating down, so the clavicle, depending on the anatomy, depending on the size of the patient, will typically cover that first rib. You're not able to feel the first rib underneath the clavicle. Down to the second rib, palpating down now to the third rib. We want to pierce over the top of the rib, not underneath the top rib. Underneath each rib, there's bundles of vasculature and nerve bundles underneath that will, one, cause pain, and then also have an impact on the effectiveness of the NCD. Another way to feel, particularly in your larger patients, if you feel down from the sternal notch, the angle of Louis, you can feel the bumps down the sternum that indicate where each rib is located, and then you can follow that out correctly to the appropriate site. Again, for this, we're looking at mid-clavicular. You can see here the heart is located. If you're too midline, you're going to pierce the heart, and that's no good. We obviously understand that. We want to go mid-clavicular, so we're going to come down again, palpating down second, third rib. We want to go over the top of that third rib. We're going to pierce 90 degrees to the patient, depending on how the patient's sitting. If he's semi-Fowler's, if he's supine, we want to go 90 degrees to the patient, so we have an anatomically correct stick. So 90 degrees to the patient, we're going over the top of the third rib into the second intercostal space. We are going to push and pierce. We're going to go through the chest wall, through the adipose and musculature. You will typically feel a pop where you're entering into the pleural space with the needle. You may also hear a hiss or a pop. Also, you can view the catheter. There may be fogging or misting or some blood return at the hub of the catheter when you've entered into the pleural space. So once you've advanced the needle, you've entered the pleural space, you have those indications. You're going to secure the needle, stop advancing the needle, and then you will advance the hub, advance the catheter down till the hub touches the chest wall, and then you will remove and you will properly dispose of the needle. You can use the tube that they come in. If you have this type of NCD, it can be placed right back into the tube. So when this is done correctly, typically the patient will have that relief. They'll be able to take a full breath. You're going to see now improvement in their breathing. Their respiratory rate can go down. Their heart rate may typically go down. If you are progressed to the point where you have tracheal deviation, you have jugular vein distension. Now we're looking at that reducing. There's no typical reason that you may have to secure this. Some people do, some people don't. It's not a permanent fix. It's not like a chest tube. It's not like an ET tube where it needs to be secured to continue to work. The muscle and anatomy shifting back and forth can kink the tube where it's not effective anymore, and also any muscle or adipose or blood can get caught up in the catheter itself and not allow it to work anymore. You'll typically get a couple seconds of relief. That pressure will decrease inside the pleural cavity. The lung will be able to expand, and then that can be left in until it's no longer effective. We'll cover that in just a second. So for the other site, we're looking at the 4th or 5th intercostal space at the anterior axillary. So you're looking here, typically mid-axillary, just front of that, you're looking at anterior axillary. You can palpate the same way you did. You can palpate on the chest down to the appropriate site. So your clavicle, 2nd, 3rd, 4th, 5th rib, 6th rib. You can palpate down the front, and then you can track that to the appropriate site, the anterior axillary. Another way to do is to karate chop the patient's hand underneath their armpit, and then underneath that pinky finger will be a good estimate of where the appropriate site for this is done. So you have palpated down clavicle, 2nd, 3rd, 4th, 5th rib, 6th rib. In this case, we're going 6th rib into the 5th intercostal space. Again, we're going over the top of the rib. We're not going underneath the rib above. And again, it's a 90-degree angle to the patient. So you're sticking here, and you're going to have all the same indicators. You're going to advance the needle until you hear the pop, hear the hiss, seeing the hub messed up or any blood return. Stopping the advancement of the needle, you're going to go ahead and advance the catheter, remove and appropriately dispose of the needle. Leaving the catheter in, letting it do its job, typically works for a couple of seconds. You'll have, again, that relief of the pressure. The lung will be able to expand typically, and you'll have that return of better respirations. Tachycardia and tachypnea are now improving. Something that can be done too, instead of securing this, it can be used just as you've seen as I removed the catheter. I have the needle safely done. If you're running out of needles, or if you have a lot of patients, say it's a mass cow, you can safely resheath these and use them again. You can use like a flush or a syringe to push any adipose fat, or muscle or blood, anything that may have clogged up that catheter. And assuming that it's not kinked or sheared in any way, you can now replace that into the site. If they have any returning symptoms, respiratory distress and stuff like that, the returning of the indications that you perform the NCD, you can retrieve it and use it again on the same patient. We're not using on multiple patients. Use it again on the same patient, either at or just around whichever site it is that you used. And then, of course, assessment and reassessing of the patient. Looking for breath sounds to return, looking for equal rise and fall. May not necessarily be equal, it may not necessarily be great lung sounds, but you're having some improvement. So you're now able to hear some lung sounds as opposed to none. You now have some rise and fall of the affected side, may not be equal, but it's not now necessarily unilateral. You're getting improvement in those symptoms. If there are any questions, comments, or concerns about this, go ahead and hit me up in the comments of this video, or feel free to message or email me either through the school or whatever the case is. That concludes now my training for NCD. Thank you.